Dr. Shinobu Aitakaki, our surgeon of the case. So we are ready to go, and the moderator will be Dr. Hadley. I will be around too. So ready to go. Thank you very much. Thank you for coming.
Thank you, everyone. I'm very honored to be here today. So today we will be presenting our last multimodality imaging conference. So we're going to go ahead and get started with our case of a 32-year-old male who had a past medical history of hypothyroidism. He was not on any medications, obesity, as well as elevated liver enzymes, which was first noted in 2019. So it was, at one point, it was thought that he had liver cirrhosis of unknown etiology, and a very extensive liver workup was pursued. Complete workup, including a liver biopsy, didn't show any inherent liver disease causes. However, it did show elevated right-sided pressures. And symptomatically, he had dyspnea on exertion, abdominal distension, peripheral edema, as well as fatigue. Eventually, a cardiac etiology was suspected, and he was referred to cardiology for further workup. So this was one of his initial EKGs. It's normal sinus rhythm, normal rate, and there's a slight right axis deviation. This was one of his initial chest x-rays, which was fairly benign. And this is one of his first echoes. I'm just going to play all the images.
Thanks, Lola, for that introduction. I'll hand the mic to Dr. Goldman to let us know what he's seeing here. If you're just joining us, it's a 32-year-old man with elevated LFTs and found to have elevated right-sided pressures, and now we're looking for a cardiac etiology.
This thing, does it work? Can we make this screen same as this?
Well, that's so we can see, they can see you.
I hope I can see the same thing over here. That's every week is the same thing. They know. Okay. Very good. Carry on.
So if you're looking for etiology for right-sided congestion, so that's a whole slew of things, going from left-sided disease transmitting back through the pulmonary circuit, isolated right-sided disease transmitting back into the IVC and hepatic veins. And then if you start externally, thinking about things, obviously, I think the topic is constriction, and we had a great presentation of that earlier last week, fantastic presentation. So without contrast, you can't really see that much actually. The only one you can see contrast is the short axis view, and that is telling you the LV function is pretty good. Pericardial thickening is sometimes difficult to see by echo. Actually, the old mode echocardiogram is actually good to show you that the pericardium is thickened or there are adhesions. So the upper left, all the other views are really hard to see. What you can see on the short axis view, which stop playing, is there is maybe a septal bounce to the septum, and you don't know without seeing EKG whether that's conduction related or not. The pericardium is a little echodense behind, but again, you need a little bit more information and other views to see it. So the other views aren't really very helpful without contrast to actually see contractility. You have to really also focus on the right ventricle of its function and thickness.
Thank you very much. So just like you summarized, it was normal LVEF and there was abnormal septal function. However, we weren't able to tell further. The M mode I didn't include because the patient was obese and it was technically difficult, so you couldn't really assess that well the septum. However, I do have pictures of the mitral inflow with the pulse wave Doppler. You can see on the left there's slight variation with the inflow. On the right, the E velocity was 0.6 and A 0.5, so the E to A was 1.4.
So it's important to be able to look at both left and right-sided filling, both the transmitral as well as tricuspid, pulmonic, aortic, as well as hepatic flow and pulmonary vein flow. And what was really done very nicely is it's good to have the respirometer on. So on that little line on the bottom is actually respiratory variation. When it, as the chest wall increases with inspiration, it rises, and with expiration it declines, and you can see at least that the left-sided pressures, transmitral pressures at least, seem to increase with inspiration. So that speaks a little bit towards ventricular interdependence, meaning that with inspiration, if you see the left-sided filling increase, that may be due to more of a constriction. The filling is usually pretty rapid, so in constriction, the early filling is normal, so you have a rapid early filling, rapid deceleration, and a smaller E wave. But you'd like to see, again, the other pressures, including the hepatic filling pressures.
Any findings of restrictive cardiomyopathy by the echo?
Really
As far as
only
thickness, strain, any of those?
So again, we didn't see that yet. They only really saw those views without contrast. We only saw the short axis, which the LV function looked good, except abnormal septal motion.
So this was the medial and lateral mitral annulus velocities, E prime velocities. The medial E prime is 14 and lateral E prime was slightly lower, but really 13.6, so pretty similar.
So a couple of important things. With constriction, the myocardium is pretty normal until the disease is pretty extensive, unless there's pericardial involvement. Whereas with restriction, infiltrative diseases such as sarcoid or amyloid, where the myocardium is abnormal, you can see distinctive abnormalities on the filling. So here, again, in the tissue Doppler, the early filling, the E wave is rapid and high, and the A is small. Whereas in restriction, because of the impairment, the abnormality is there even at the beginning of filling, even the E wave is diminished. So the presence of an E wave more than 12 is actually pretty indicative potentially of constriction. The other is looking at pulsus inversus, that in constriction, because of restraint of the pericardium to the myocardium, the lateral wall, which normally moves more than the medial wall, the septal wall, here, the S waves are similar, which again is indicative of the fact that there's some type of restraint which could go along with constriction. So this tissue Doppler is actually very helpful because the transmitral can be similar in both restriction and constriction, whereas the tissue Doppler is clearly different. And this tissue Doppler would be more consistent with constriction than restriction.
And this was the hepatic vein flow with.
So the hepatic veins are actually very helpful. So the hepatic veins is sort of the opposite of the pulmonary vein inflow for the left atrium. The hepatic vein tells you what the IVC is seeing as far as right atrial pressures. So in ventricular interdependence, typically when the patient would inspire, take a deep breath in, they would fill the right-sided pressure to a greater degree. Then expiration, you can get reversal, because now that the left ventricle is filled at the expense of the right ventricle, the right atrial pressures are higher, and sort of there's resistance in inspiration towards hepatic vein filling. With restriction, you actually have the opposite, that the abnormality is there during inspiration. You can't really fill anymore, so you may get reversal. Here, there is a hint, at least, again, with inspiration, there may be a little bit higher filling than expiration. It's not that clear, it's suspicious for it at least, and it would not be against what everything else we've seen. So in toto, the Doppler, which is extremely helpful in differentiating constriction from restriction, would seem to favor the diagnosis of constriction.
And the hepatic vein was plethoric and there was no compression with inspiration on the right. And this is the tricuspid inflow. again, you see slight variation, but not significant.
So again, it would appear that it increases with inspiration. You know, if you look on the pattern, just look at the left-sided pattern where the bottom green line is increasing. It looks like the inflow pattern of the tricuspid valve, the peaks of those are higher during the subsequent part where the green line is dipping down with this expiration. So again, all of that would be consistent more with constriction. Ventricular interdependence is the key finding, that constriction, there's external limitation because of the very thick pericardium. The total volume of the left and right heart is restricted, pardon using that term, but basically it's fine, it is limited. So if the LV fills more, it does it at the expense of the RV. If the RV fills more with inspiration, it does it at the expense of the LV. So therefore you get the respiratory variation in filling of both the LV and RV, which you don't really get with restriction because the disease is there all the time throughout the cycle.
So Dr. Goldman, sounds like based on this initial echo, you're leaning towards constriction. Would you be ready to send this 32-year-old for sternotomy, or would you want to be looking for more information?
No, I think that again, it's really important. Number one is you have to evaluate, going back clinically about the liver, that's really important. So is the liver prohibitive for doing any surgery whatsoever? So you need to assess the liver. If there was a question of cirrhosis, that may be an issue. But presuming the patient is a surgical candidate, you know, the multimodality experts you have up here, MRI, CT are really very helpful to tell you more about the pericardium and the pericardial thickening. And then cardiac catheterization, Dr. Dengas is an expert in hemodynamics, so will tell us more about whether the hemodynamics are consistent with it or not.
This is not a skin biopsy. Before you send the patient to surgery, you have to be pretty sure. This is a morbid operation, and it's worse if you're doing it for the wrong reason.
Dr. Hidegaki, do you ever take patients based on just an echo for pericardiectomy?
Not just by echo.
Yeah. All right, let's look at some more. Let's look at some more.
Should I go with echo teaching slides or continue?
I think you did a really nice job summarizing, but I think let's bring it all together at the end if we have time with your slides. Yeah.
So then the patient, based on the echo findings and the abnormal EKG and his symptoms, had an MRI to look for further etiology of his right-sided elevated pressures.
Why not cath first? What would, I mean, we just already heard that we wouldn't take the patient to the OR with non-invasive imaging, even though I'm sure this MRI is gonna be fantastic and it's great. I'm not, but why not, I'm trying to understand the way that we're thinking. I mean, I think the guidelines would say, you're thinking about constriction by echo, the symptomatology may fit that. The next step is to do invasive cath to evaluate the hemodynamics and to be sure that you're dealing with the right thing. And then if you want it as a extra, if there is some issue, then go to MRI perhaps. So try to, maybe I just don't know enough.
I think at that time clinically, like constriction wasn't really the first thought, just based off of the echo, and they were just looking for a broader differential.
I think first of all, this is multimodality conference, so that explains it.
No, I understand that, but I'm
Secondly, I
just trying
think
to
that
understand.
no single test is going to be necessarily 100%. You have a preponderance of evidence to tell the surgeon to take a scalpel to this patient because constriction, and I'm sure that we'll hear, constriction surgery is very difficult because there's frequently involvement of epicardium. So it's a major operation and it's not inconsequential. So I think the more information that you have, particularly in this patient who may have some liver disease, the more confidence the surgeon will have that he's going in for the right reason. And I think that, the echo, just as you said, is suggestive of, and there isn't a single test which is going to be 100%.
And the echo was a little bit limited technically because of patient habitus. So doing an MRI that is not limited is, I think, very appropriate. We don't use it that much because it's an expensive test, difficult to order, how do you get it? So there are a lot of logistics around it. But if it was abandoned, we'd be getting it all the time. And, it's just a matter of how you plan and, if there's a spot for the MRI, then you do it quickly. If not, you just have to wait. So then the cath will be done before, but essentially you need both of the
To Roxanne's comment,
aspects.
sometimes the cath is just another piece of the puzzle. It's rarely,
I just
I
think,
think,
the way we
definitive in
go.
terms of what you need to do. You're gonna need all of the above.
You establish both the anatomy and the physiology of the disease. Cath and echo are very good for the physiology of the disease, but not very good for the anatomy of the disease. CT and MRI are great for the anatomy of the disease. MRI can give you a little bit of both.
Okay.
So here, there is a 4, 3, and a 2 chamber. On the 4 chamber, you could see the right side. It's not severely enlarged, it's contracting, so it was normal function. Maybe there's some mild TR, but otherwise, this is the cine images.
But you can see the bounce much
Yeah,
better
you
than
can
echo.
definitely appreciate the
Septal.
septal bounce. Yes.
I agree with those points. Also on this differential constriction restriction, looking at atrial size can also be helpful, right? In a restrictive process, usually you get dilation of the atria. Here, I think maybe mild to moderately dilated. This was, significant restrictive process, I'd expect larger atria. And then you saw that the bounce, I think maybe if you have a short axis, we'll see that septal bounce better.
Yeah.
Dr. Goldman mentioned that conduction is on the differential. We saw the EKG look like pretty narrow QRS, so likely not conduction here. You see that little shudder in early diastole, which probably corresponds clinically to the pericardial knock, because you have that really high atrial pressure, fluid rushing into the constricted ventricle, and you get this
gorgeous
shudder.
pictures.
Yeah, the middle line, the
That's why we
middle,
do the MRI.
the middle slice is,
Right.
yeah.
You can
Also the pericardium,
Uh-huh.
and you will talk later that maybe fluid or fat between the two layers of the pericardium.
Yeah,
It's also suggestive of thickness.
Dr. Guru said that we can get some information about the pathology. So what's information on the pathology of the pericardium that we learned from this study? Is it fibrotic? Is it, well, why would there be constriction based on the anatomic, hints? We understand the septum and all that, but any findings in the pericardium?
Yeah, I think maybe the next slide, let's see.
Upper enhancement.
So in this slide, this is actually just a free breathing, so you can see the diaphragmatic excursion. With inspiration, it's going down, expiration, it's going up. And as you inspire, the septum is shifting to the left, and with inspiration, it's shifting back to the right.
Okay.
Yeah, go play smoothly. This is beautiful.
Yeah, this is the
this
best
is a
image.
really great example of ventricular interdependence. And you see both with inspiration, you're getting that shift leftward, and then with expiration, you get that shift rightward, which to Dr. Goldman's point is what causes that high right atrial pressure, expiratory diastolic reversal of flow in the hepatic veins. There's some of this you'll see at baseline just physiologically, but this is much more dramatic.
This is dynamic imaging, Unbelievable.
What I find the easiest way to think about this is the pericardium makes the ventricles a steel cage. Any filling of the RV has to occur at the expense of the LV and vice versa, because the pericardium imposes a limit on the volume, total volume can be in the pericardial space.
Okay, so then we have some parametric analysis. So T1 basically trying to see if there's any fibrosis within the myocardium. Looks like the relaxation time was 1004, which is within normal limits, and everything is sort of orange in this color scheme, which is normal. If it was abnormal, it would have been in the lighter ranges. So T1 was normal. And T2 was done to see if there's any edema. On the left here, if there was any edema, you would see areas of patchy, fluffy white areas, which we don't really see. So there was no acute edema. And on the right here, this is a fat suppression image. So I'm just gonna go back to the cine images to compare. So here you can see like outside right here, this would be epicardial fat. And then this layer within, it's either pericardium or it could be fluid or it could be fat. So that's why we go back to our fat suppression image. And here you can see the epicardial fat was suppressed. However, this area is not suppressed, so it's probably a thickened pericardium at this point.
That's cool.
How thick is that?
It's more,
So we measured it in the next sequence. So this is your your LGE sequence. So this is where you would see if there's any scar. And you can see that there's circumferential enhancement all the way from the apex to the base for the pericardium. It's circumferentially enhanced and it's quite thick, and measured at different areas. It measured between 4 and 5 millimeters, all the way from the base to the apex again. And there was no myocardial enhancement, so it was all pericardial fibrosis and inflammation,
So
chronic.
that goes against the restriction, because in restriction you can have some delayed enhancement of the myocardial.
But is,
Yeah, a restriction, you would have myocardial enhancement, correct?
is the thickness of 5 millimeter by itself very excessive that can be diagnostic just as a measure of how thick it is?
More than 4 is,
Normal is supposed to be 2 or less,
Yeah.
but when you get in the 4 range, there's a series, I think Rick Dishon published a series where he described 20% of cases that surgically confirmed constrictive pericarditis had a quote normal pericardial thickness, which kind of worries me, but I wouldn't want to send somebody to the OR unless you have a thick pericardium.
So 5 is a very thick expression.
So it's both thick and it's taking up a lot of gadolinium, so it's very fibrotic as well, which wouldn't be normal. And I think the tissue, to your earlier point, Dr. Dang, is that T1, T2 mapping shows there's no myocardial pathology, right?
Yeah.
So that kind of narrows down the differential a little bit. It shows also that there hasn't been a prior myopericarditis that precipitated this. There's no residual scar of the myocardium.
So going back to the etiology that you were saying, post-viral is probably the most common, but the other obvious things that you wanted to worry about, which she didn't have, infections, TB, radiation is a big thing, trauma, but she didn't, post-operative, that we see sometimes, but she didn't have any. Idiopathic is the most common, and, you're groping, and I think that's maybe why they went down the liver disease as a
And
manifestation.
any role for a CT to see if it's calcific or not, or like a non-con
yeah.
CT?
We have a CT.
Oh, we have that too.
Very good.
So,
Next one.
sorry, this is the last MRI image, so these
It's
are
on the
just
cash register.
2, 3, and 4 chamber. Again, you can see that the myocardium is pretty homogeneous, however, the pericardium is very bright and circumferentially enhanced. And then at this point, the patient was sent for cardiothoracic surgery evaluation prior to a CT at this point. Initially, in December, he was seen and he was started on Lasix and just monitored for symptoms of increased shortness of breath or chest pain. And 3 months later, he did come back with worsening cough and chest pressure. At that time, he was sent for admission, an echocardiogram was repeated, a CT chest was done, as well as a left and right heart cath.
So during these 3 months, the diagnosis of constriction was in the play but not secured, is that
Right,
correct?
right.
So that's why you sent the patient because of the worsening or?
Patient was admitted because of worsening symptoms. And further workup was pursued to sort of, I guess,
So the Mayo actually published a couple of years ago that patients with constriction, some patients with moderate constriction can be dealt with just medically, just dealing with their elevated pressures, and not all patients. So it wouldn't necessarily be inappropriate, to sort of follow the patient and make sure they are, can't be dealt with medically before, readdressing it. And it looks like despite medical therapy, the patient got worse, not better. How about the liver functions, which obviously is subtle and important? Were they abnormal? Do they show, because the initial presentation in 21
He
was
did have,
possible cirrhosis.
abnormal LFTs, so it did suggest hepatic congestion, which is why all this workup was initially pursued. But he didn't have any primary GI issues.
So no cirrhosis. There was
No cirrhosis, it was just ascites and liver congestion. There was no etiology of why he could have possibly cirrhosis, but no
How much
cirrhosis.
ascites was that?
I have a CT with a moderate sized liver.
And was it obvious on exam that the belly was big or?
I think that was his presenting issue, I think.
It was his
to an outside
presenting issue.
hospital
I
or
actually
some
didn't never see the
scientist.
patient myself, but that was his presenting issue. He had lower extremity edema, abdominal distension, shortness of breath, fatigue, but clear lungs.
So getting EMP is sometimes worthwhile because the EMP would be normal most of the time in constriction until the pressure is very high, but would be abnormal with restriction because of the abnormal myocardium. So that would be an interesting biomarker.
And any aspects of PT, INR, any of those were elevated? Synthetic function of the liver was affected or not?
I don't believe they were affected.
Question is also, when you're getting the right heart cath, maybe Dr. Dangus can get a sample from the liver also, just to kind of clinch what exactly is going on with the liver before you move forward. Might be
Confirmed
helpful.
congestive hepatopathy is not something else.
So his PTINR was always normal. In terms of his LFTs, they were elevated, but I'm not sure if there was any diagnosis of why he had elevated liver enzymes, which is why the cardiac etiology was pursued.
And how was the suspicion of elevated right atrial pressure? Was that by physical examination, or had someone done a cath before? Do you know?
No, there wasn't any cath, but they had done like an abdominal MR elastography and other, liver. That's how they
And that's
found the
what
elevated.
suggested-
That's how they found the congestions on the right
Just
side.
another word of caution. You can see that in acute processes, you can see both thickening of the pericardium and constrictive physiology. That you just wait medically and it goes away. You just have to be a little cautious before you jump in. Surgeons know better, but we should know better too.
And sorry, to answer your other question, his BNP was around 150 and his
Low.
Yeah, low. He is obese, but it was low. And his tropes were also within normal limits. So at this point, he was sent for admission for worsening symptoms, and this was his CT.
It's a non-contrast CT. You can very clearly see the pericardium is thick. Normally it's a thin line you would see. It's actually very thick, like somebody drew it with a highlighter. And so the thickening of the pericardium is a sensitive marker in the sense it's usually there when you have constriction, but it's not specific. You may have thickened pericardium and normal physiology. So again, you have to prove both the anatomy and the physiology. This is just one piece of the puzzle, but this is good to show the surgeon there's something to go after here.
And there's also focal areas of calcification.
Not much though. Yeah. Not much calcium, but definitely thick pericardium.
So when we did further review of his history, this was in February 2023, but he did have a abdominal CT in 2019. So this was a CT-AP, and in this one you can also see that a few years ago he did have that pericardial thickening. However, there was no calcification at that time, and this is the ascites that he had on this image.
Oh, wow. Back in 19.
2019, which is when he had the abnormal LFTs and all this workup was pursued. So this is his ascites. Yeah.
It's 4 years worth. Less than that too.
Dr. Gurudevan, I think those of us who don't do CT every day, we often think of it as just static images. But you can do a gated CT where you look at different phases of the cardiac cycle. Do you think CT is a useful tool to look at things like ventricular interdependence?
What we're lacking now in CT is temporal resolution, because the temporal resolution is not as good as echo, MRI, or cath, but it's improving. Actually, we're getting a new scanner at Morningside, a dual source CT, which has a temporal resolution of 70 milliseconds. It's very good. You'll be able to see the different phases of the cardiac cycle with a lot better enhanced. Then we'll be able to talk about physiology as well as anatomy from CT. But right now we use CT as just anatomy. Is it thick or not is really the question we're asking.
Is it thick or is it calcific? Looks like it's thick and it's not calcific. And that's a good use.
Where is this patient local? Were they somewhere else where they were exposed to things? Do we know?
No, he's from here and he's local. He doesn't have any travel history. He didn't have any TB.
And there was thyroid
Not
disease.
incarcerated. He did have thyroid disease, but he wasn't on medications, but his TSH was fairly within normal limits, so. So yeah, he did have a left and a right heart cath, and I do have the LV and RV tracings.
You want to see RV first? Or do the next?
This is his RV tracing.
Yeah, well, just from the numbers we saw in the beginning, we
Go
saw
back to the
that
numbers, because the numbers.
LV pressure is borderline, low really, about 100. And the right side pressure are all essentially very normal on the systolic phase. And the diastolic pressures are elevated throughout. Just by looking at that, you're posing a question of constriction, and you're essentially ruling out a restriction because you don't have high pressures. And particularly this corroborates a low BNP level that again indicates absence of left heart failure propagating to the right side. I mean, the systolic pressure of PA pressure of 40, you see it's very low. So you have a heart failure with a low systolic PA pressure or systolic RV pressure, however you want to call it, that is right away highly suggestive of constriction. And we'll go to the RV pressure tracing. If you can go there, you can also verify that there's a square root sign and all these things you expect in diastole. However, look at systole. This systole is a very low number and it's a peaked tracing. This is not a classic tracing that we see with a peak and plateau in both LV and RV. This is an unusual hemodynamic tracing that again points into a systolic limitation in the RV ejection. And we go now to the previous slide that shows the ventricular interdependence, which interdependence by that word means that one ventricle is dependent on another. So you can see on the left side, the first 5-6 beats, the trend in the systolic LV pressure is opposite to the trend of the systolic RV pressure. So that is a typical and essentially pathognomonic sign of ventricular interdependence, and that seals off the diagnosis of constrictive pericarditis in this case. And again, we have to be a little careful because we're going into this cath, and everybody talking about diastole this, diastole that, and the findings in the cath are mostly focused on the systolic numbers, in the systolic pressure trends, and in the systolic tracing configuration. So you just have to kind of switch your thinking. And if you focus only on the diastolic, there will be a lot of, I would say, overlap between constriction and restriction. That's why you have to focus on the systolic in order to tell them apart. And I think there's a very nice example.
Can you repeat, excuse me, I want to understand that, the systolic aspect.
Yeah.
Why?
Because you can see the trend of the systolic pressures go down in the LV and go a little up in the RV, and the opposite in some other tracings there. But go to the next aspect, please. And then and that is reflective of what we measure as a mitral valve inflow abnormality. This means the heart, the LV is by echo, for example, or the MRI, doesn't have enough blood in it, and therefore the next ejection is going to be low. And if it continues like that in that same respiratory phase for a few beats, progressively the LV pressure will go down because it's beating while it's underfilled, and at the same time the RV is going up because it's overfilled and has more ejection. But the diastole, everything seems to be filled anyhow. So remember the
problem is with diastole, it can't fill, but the manifestation is easiest seen in the systolic events here, which represent underfilling. And it's underfilling depending on who got there first.
Exactly.
If the RV gets there first, the LV is grossly underfilled. If the LV gets there first, the RV is grossly underfilled.
Right.
And if you look across the tracings that George has with two ventricles, what you're looking for over time is there's a gap and then the gap narrows, as opposed to them tracking each other up and down. That makes it easier to see. You don't even have to look at the numbers, look at the pattern. They spread out, then they come back together.
Yeah,
That's interdependence.
And ideally you have to set the pressure scales so that you can see clearly, more clearly the systolic. So I would have chosen a little bit of a bigger scale so you can see those pressure tracings. Right now they're kind of a little bit compressed, that essentially utilizing half of that. Maybe you could have gone to 100 scale so you can blow up, magnify them a little bit, and then you could have seen the trends a bit easier, a bit more easily.
We talk about equalization of diastolic pressures in constriction. Sounds like that's not as important on the cath. It's more about the systolic.
It happens in both constriction and restriction pretty much. So it doesn't really help you tell them apart. Of course, it's an interesting finding because they're abnormal. The diastolic pressures are abnormal, but that don't help me to understand if it's constriction or restriction. If you tell me all of a sudden the PA pressure would be 75, I would say my first bet right away, based on that number, would be restriction, and we'll go from there. And but here we're starting with equalization of pressures and a systolic of 40. By far, right away, based on this number, my bet would be we're dealing with constriction. Let's try
There's one
to see.
issue though here. First of all, this is not described in the classical constrictive pericarditis hemodynamics, and I think I begin to understand what you talk. If you have a severe case, you will see the systolic pressures.
Yeah.
But if you have a less severe case, the diastolic dominates, the equality between both. What I'm really saying is to go into the systolic pressures diagnostic, I would say is a diagnostic of severe constrictive pericarditis.
Oh, no question about it.
But just a
100%.
moment, where the sensitivity is higher with the diastolic equalization of pressures, whether it's mild, moderate, or severe. I think this is important because otherwise we can leave these rooms thinking, I'm going to look at the systolic pressure in every patient, and I think it's only in the severe ones. Otherwise, the diastolic pressure is much higher sensitivity. In the books, this is not, I mean, this is, what you described to me today is new. I never heard of it.
Well, I mean, considering the evaluating cases of possible surgery, we have to go to this because I would not, wouldn't want to refer them to this. Actually, we have a case of mild. Dr. Fuster indicates exactly that we have some diastolic abnormalities with not yet any systolic abnormalities. You can all visit CCU Bed 1.
Okay, thank you.
So not in the real world, but in a textbook, this is what it would look like. So the square root sign, like you were talking to us about, it just demonstrates increased filling pressure in both constriction on the top and restriction on the bottom. And with constriction, you can see with inspiration, there is decreased filling of the LV and increased filling of the RV. And with expiration, it's the opposite. There's decreased filling of the RV and increased filling of the LV. And in restriction, there's no respiratory variation.
Goodness, you want to just use the terms concordance or discordance and explain how those are used?
We're going to have a full conference about that in July, so we can review on that. But essentially, you have to trend 3-4 beats in a row in order to be able to have the lines. And if concordant and parallel to each other, LV-RV trending in the systolic pressures, then you have concordance. If they're trending differently, you have discordance, and discordance is indicative of restriction. But look at what they do over here. PA pressure near 50, PA pressure near 20 at the top. That is a very crude and easy way to screen your mind. If you want crazy about the square root sign and all that, absolutely you can. Or you can just say, oh, it's in the 20s. That's likely restriction. Or look at that, it's near 50. And they don't make sense of that, but clearly you can see that they have plotted much lower normal, essentially, PA pressures in the constriction phase and much higher pressures in the restriction phase. I would have plotted them even higher, actually, above 50 here.
This was a intraoperative TEE where you can see the thickness.
You didn't pursue the liver? I mean, no biopsy of the liver, nobody?
They did a biopsy of the liver and it was completely normal. Yeah, that was like even before he was sent to cardiology, which was back in 2021.
Before we go to the surgery, can you tell us how you put the case together and why you were confident to take the patient to surgery?
So at this point,
The surgeon. The surgeon.
oh,
Yeah,
sorry.
so I think it was a good example of multidisciplinary approach to the patient. So I talked to each one of the person who was involved in this workup. I talked to liver, I talked to you, I talked to Mike Crowley, I talked to Greg, I talked to Dr. Dangas, who was referring me to this patient. So everybody has different level of certainty about diagnosis, but and then right heart cath was the textbook findings. I also talked to Dr. Jacobi, who read the MRI. So I think MRI finding, he was very confident about that constrictive pericarditis because of ventricular interdependence and very thick pericardium. he said he doesn't usually even see the pericardium on the imaging, but he saw a very distinct image. And on the CT, there's a bit of calcium in the pericardium, which is very unusual for the regular patient. And Dr. Goldman was very sure about its constrictive pattern, which also made me very sure about it. So not every single finding was typical for the constrictive pericarditis, but everything all put together. And I also took liver. Liver said it's definitely not the liver issue, it's something from the heart. So I think that's also very important. So all put together, I think, and then he's young, and then the right side pressure was high, with normal function. So I wasn't still 100% sure until I see the pericardium, but by the time I go to the OR, I was pretty sure that it's probably the constrictive pericarditis.
What else you would need, I mean, to be more sure?
Hmm?
No, I mean, besides seeing the pericardium, what else you will need to be more sure that it's constriction? You know what I mean? I mean, there's nothing else to do.
Nothing else.
Sorry,
Yeah.
because it's,
Yeah, I wasn't.
besides seeing the pericardium, I mean, there's nothing else you can do.
But only he can do that.
Yeah, no,
No,
that's
but the question is not the pericardium or that. The ultimate question is this patient going to have a clinical improvement after a rather morbid operation to take that thick, 5 millimeter thick pericardium out? And that's, I think, what Shinobu is referring to, that, you know, the panel always say, and pericardium abnormal, and this and that. The question is, will the patient derive any benefit? The surgery is complex, is tedious. So, did the patient derive any benefit after the procedure?
That's why you want to be sure before you go, because if you take someone with restrictive disease
Right.
and bring them for this operation, not only will Shinobu not find anything, but now you've taken somebody with restrictive disease and impaired cardiac function and subjected them to the thoracotomy and all the hemodynamic changes and the recovery from it as well.
But
And
is
that's
it possible?
dicey.
Is it possible to, if you're really unsure, because I don't know, there must have been some mixed messages, because to us, it looks like it's a very clear message. This was, but it sounds like to you, it was a mixed message. So I think that's like, I mean, to me, what's being presented looks very much constriction. If you're unclear, let's say, could you do like a window or something like that which is a less invasive? Would that help at all? Or do you really need to take the entire thing off to see the improvement, or some improvement because you don't want to put a patient through if there's truly an issue? Is there a limited operation?
To make a diagnosis or to make the patient better?
Either.
Either one. I just want to understand, because I'm sorry, I'm sitting here, I don't see why there was any, you must have had some unclear understanding whether it was going to be, but it seems like all the modalities are showing constriction, including the cath, including the MRI, including the CT, including 4 years of watching this patient from 2019 with moderate ascites, and maybe we needed Dr. Fuster at the bedside to see the neck veins. But I'm just going back, seriously speaking, is there a limited operation that one could do to?
I think you could have done a window,
Yeah.
probably take a look if actually the pericardium is thick. I could have done that,
Yeah,
to be
in fact,
sure.
I was at Mayo, let me tell you, I was at Mayo 30 years ago. And I had 3 or 4 patients, and in fact, this was the question. It was a very limited operation. I still remember Dr. Dwight Magoon said, with just a window, and you can see if there is pericardial thickening or not, with a very, and today with all these imaging technologies, I don't think you face
need
this
to
so
do that,
often,
right.
but in the past was a real issue.
I think it's also important to put in context. Retrospectively, it's very easy to say, oh, this is constriction.
I understand,
But in context of following the
Yeah.
patient, Dr. Shinobu had to make a very difficult decision to take a patient who potentially was ill with liver
Yeah.
issues.
I'm sure
Can
you
you
are
tell
not.
us what the surgical findings were?
So surgical finding, as soon as I opened the chest, took a look at the pericardium. From outside, it didn't look so abnormal. But as soon as you open the pericardium, it was very thick, like a 3-4 millimeter. Usually it's like a 1 millimeter. And as soon as he opened the pericardium, the heart almost was bulging out. It seems like the heart was very, very heart was very, very
Heart was
constricted.
changed. You uncaged
So
it.
it was immediately obvious that
Unchained.
it was constrictive.
Django Unchained.
Yeah. And it was very adhered inside. It was very abnormal pericardium. So at that moment, I was 100% sure.
I have two comments. One, you will believe it, and the other, you will not. The one that you will believe it is that magnetic resonance imaging has been the most prognostic tool to know if the patient is going to do the delayed enhancement. If there is no fibrotic myocardium, these patients do very well. In the past, this was not available. But what I'm saying is surgeons are always very worried about constrictive pericarditis, is the myocardial involvement with the fibrotic. The thing you will not believe is that in the differential diagnosis in constrictive pericarditis, you don't feel the right ventricle. In the restrictive cardiomyopathy, you do. I'm telling you, I know you do not believe that, but I can show you in the bedside, as you many times.
That's called a broad bedside.
Well, you know, what I'm saying is, there's something else than imaging that is still, it still may work for you. Very cheap.
I say it's cheaper.
That's what I'm thinking.
But you put these guys out of business.
Dr. Fuster, this clinical presentation
Well, not all the time.
was a liver,
Try to do
neck
that
veins,
often.
and clear lungs on the x-ray. That constellation makes a slam dunk for constrictive disease. Clear lungs is not heart failure. The big veins and the liver is commonly involved with constrictive disease, and many patients present exactly like this patient, and then nobody looks at the veins, and therefore they get involved with the liver. If one looked at the veins in this patient, the liver workup is worthless. And it's simple at the bedside to take
The
care of
lungs
this
being
patient.
clear, the lungs being clear is a good point.
Exactly, so it's really quite simple. Well, I know it's very elegant, all these other studies, but at the bedside,
I just wanted to show you guys a video. This is not this patient. It's not this patient, but it's a
Oh,
example of a patient of Dr. Guru's, I believe. Correct?
It's actually not my face. This is given to me by a colleague, an Echo family WhatsApp group who's a pericardial stripping procedure, I think in another country. But an example of this is really not easy in some cases. It's really densely stuck to the visceral part of the pericardial. It's like peeling a sticker off of an old window, old sticker off, but the problem is the window bleeds. You try to peel that off. And so it's just hard, it's very difficult, it's bloody, nasty.
Dr. Itagaki, anything to add?
how was your operation like that?
Yeah, pretty much like this. It was very severely adhered pericardium and heart. We have a bypass just standby, just in case we have to go on bypass. Fortunately, we didn't need to go on this case. Then just to strip the pericardium from phrenic to phrenic.
On the intraoperative transesophageal echo, do you notice changes once the pericardium's up? For example, I understand sometimes when the heart can relax, you may get annular dilatation. You may unmask regurgitant valve, and then while you're in there, you can go in and fix it. Anything that you're looking for before you go back and sew the patient back up?
Yeah, on the echo, it didn't really. I'm not sure actually.
Okay.
But the heart looked happier.
So
I have a question.
one second, this is closed heart surgery. You put the patient on bypass for this?
No, he didn't.
I didn't.
No.
Yeah. But
No.
sometimes
No.
it's yeah.
Sometimes you need to do that?
Right.
And how do you reconcile all the bleeding that happens
That's
when
what I
you
want to
peel
know
off
is
the?
what do you do with the bleeding around the heart? And
Well-
is there post-operative bleeding, but there's no pericardium to keep it in, right?
Right. We just carefully do the hemostasis for each time, and you can still use the Bobby. Yeah, just to carefully dissect.
And then you give protamine at the end?
Yeah, protamine. Yeah. But yeah.
We're close on time,
Better
so
without.
you want to bring us home, Loba?
So this is just a post-op echo, which is just showing fairly normal wall motion and EF. And I just have a few discussion slides sort of to summarize everything we talked about. Most of it we already talked about. In constriction, you have a disassociation of your intrathoracic and intrapericardial pressures. So in inspiration, you have this drop in your intrathoracic pressure, which usually transmits to your wedge pressure. But in constriction, your intracardiac pressure drop is blunted because of the constriction. So then you have a reduction in your mitral inflow. But then with expiration, your thoracic pressure increases and you have increase in your mitral inflow. So it's the same thing showing here, which is what we were talking about with all the echo images. With inspiration, your intrathoracic pressure drops, your venous return increases, your RV fills, and your septum will shift to the left. And as it shifts to the left, your mitral inflow will decrease. And the opposite with expiration, your intrathoracic pressure will increase. As a result, you'll have increased filling of your left heart, and then the septum will shift to the right. And in this case, the mitral inflow increases, but at the same time, there's retrograde expiratory diastolic flow reversal, which you would see in your hepatic veins, which we had already talked about. And this is the echo M mode, where you can see the interventricular septum. With inspiration, it shifts to the left. Expiration, it shifts to the right. And you can also see shudder, which we also talked about, which is just due to differential timing of filling in the pericardial constraint. And not imaged here is a pericardial thickness of TEE. If it's more than 3 millimeter, then it's sensitive and specific heart constriction. This we also talked about the mitral inflow. With inspiration, you would see a drop in inflow, and with expiration, you would see increase, but the drop should be more than 25%, which we didn't see in our patient. And with expiration, with tricuspid inflow, it's going to be the opposite. You'll see 40% increase with inspiration, which we also didn't see in our patient. And there has been larger studies which show that the absence of these findings is not going to exclude constrictive pericarditis because it's only present in 1/3 of the patients. Hepatic vein, you see the diastolic expiratory flow reversal. And the other concepts are annulus paradoxus and annulus reversus. Annulus paradoxus is showing that the mitral E' velocity persists to be high even when there is abnormal diastolic filling, which is not normal in abnormal diastology. And annulus reversus, the lateral E' will be lower than the mitral, and that's due to the lateral tethering of the LV. So this is just a summary of the findings by echo, which ventricular interdependence, which we sort of saw. Mitral annulus E' velocity should be greater than 9, is usually greater than 9, which we also saw. Restrictive pattern of the inflow, hepatic vein expiratory flow reversal, and the plethoric IVC, which also our patient had. And for myocardial deformation, the top left here, this is more like a restriction where your longitudinal strain is reduced, but the apex is spared. And then the bottom right here, this is showing your constriction where the longitudinal deformation is actually preserved. However, circumferential is reduced. And in the longitudinal, usually the lateral is reduced while everything else is spared. And this is just an example of apical HCM or apical infarct, where the apical strain is only low. So the pathology we already kind of discussed. It's just an encasement of the heart with a thickened fibrous and sometimes calcified pericardium, which ends up causing diastolic heart failure, which results in restrictive filling in the presence of normal systolic function. And it can be idiopathic, which is probably the case in our patient, can be iatrogenic, such as post-surgical inflammation or radiation therapy, which our patient didn't have, connective tissue disease such as RA and SLE, history of infection such as TB or histoplasmosis, you can have neoplasms or uremia. And the differentials could be constriction, restriction, or ischemic or dilated or valvular heart disease. For restrictive filling patterns. And clinically it's important to differentiate constriction from restriction because constriction, you can do pericardiectomy or place patients on NSAIDs and anti-inflammatory drugs for treatment, whereas restrictive cardiomyopathy, the treatment is fairly limited. And this is sort of a multimodality approach, which our patient had. E prime velocity, if it's medial E prime, if it's increased, it would favor constriction. If the lateral E prime is reduced compared to the medial, that would also favor constriction. The other things we look for is the transmitral flow, which is increased, which you would have increased respiratory variation with both the mitral and the tricuspid, as well as the septal interdependence. Those would favor constriction. Hepatic vein flow reversal favors constriction, and then you can see in CT if there's pericardial thickness, if the contour of the pericardium is deformed. And as we had already discussed, if there's biatrial enlargement, it would more favor restriction. And in MRI, you would also see pericardial enhancement and thickening. However, in restriction, you would see atrial enlargement, abnormal wall thickness, and you would see myocardial scarring in the LGE sequences, which we didn't see in our patient. And if it was amyloid, you would see abnormal nulling.
It's a great summary. Thank you so much, Loba. I know we're short on time, so we gotta let everyone go.
How's the patient? How's the patient?
Patient is doing well post-surgery. I think most recently he was seen for chest fever, and he's been treated for that.
I call him on the weekend how he's doing. He feels much better, more active,
Excellent.
lost his weight.
Strong work.
Yeah. So clinically he's
It's
better.
difficult to overemphasize Dr. Sklerov's comments. Most liver patients sink fluid into their belly and elsewhere. Their neck veins aren't high.
Right.
High neck veins, LFTs, it's the heart.
Yeah.
I mean, it's not always constricted. They can have right heart failure, et cetera.
The right heart failure will be diastolic, this chronic diastolic dysfunction, whatever that may be, you go find the differential. Right.
Thanks, everyone. We'll see you in the fall.
Nice work, everyone.